Dr. PREMA Padmanabhan, ma'am, who is the distinguished senior consultant in the Department of Cornea and Refractive Surgery at the prestigious Shankara Nethralaya in Chennai. Over to you, ma'am. Thank you.
Thank you. Good morning, friends. Gives me immense gratitude and humility that I find myself standing here to deliver an oration that bears the name of someone I have held in such high esteem and whom I have idolized all through my professional life. And for this honor, I am grateful to the AIOS. This oration actually celebrates a living legend. He is not only shaped corneal care in this country, he has literally breathed life into the very concept of eye banking in this country. Not only has he given, but he has facilitated the gift of vision to thousands of patients. And his own vision has been a gift to an entire generation of ophthalmologists. I was not fortunate enough, and I'll be honest, I was not smart enough to be his student, but he was always kind enough to be my teacher. At the heart of his philosophy lies a truth that he has always championed. He has always believed in the merit of partnership, not just among the ophthalmic community, but across disciplines. And I hope that my talk today will honor that very spirit of synergism that he has nourished. I respectfully acknowledge the team that I've been working with, headed by Professor Krishna Kumar, a very senior professor in the IIT Madras, Dr. Srinivasan of the JK Tyres, and Karthik, a PhD student. What started as a very casual conversation with them soon became fascinating and then compelling as it evolved into the presentation that I'm about to make. This basic description of the cornea is as simple as it can get. But what's interesting is that it would read exactly the same if you change the word cornea to an automobile tire. Unlikely as this analogy may seem, the similarities are striking. They are both multi-layered composites, every layer being morphologically distinct with a specific composition and a unique architecture that is designed to integrate its structure with function and behavior. The collagen in the cornea, like the fillers in the tire, are what give it stiffness and strength. The proteoglycans in the cornea, like the rubber in the tire, give it viscoelasticity. And if you were to draw a stress-strain graph or a time-dependent stress relaxation graph for each of them, they would look identical. The orthogonal placement of the fibers in the cornea, like the belt package in the tire, lend meridional strength. The circular fibers of the cornea, like the bead and the body ply in a tire, give it circumferential strength. And the depth-dependent placement of these fibers make both anisotropic. So even if the magnitude of these properties are vastly different, their nature is very similar. They are both nonlinear, viscoelastic, non-homogeneous, anisotropic structures. What about the stresses they are exposed to? The intraocular pressure and the inflational pressure in a tire are what generate the tangential tensile strength and the radial compressive stress. And every time the eyeball moves against a blinking lid or the wheel moves over a tire or over the road, you get the hoop and the shear stress. So again, the magnitude may be different, but the nature of the stresses they are exposed to are very similar. Both the cornea and the tire need to maintain a delicate balance between stiffness and flexibility in order to absorb the energy from minor impacts like rubbing the eye or a vehicle moving over an uneven road. But when there are cobblestones that jut out, whether they jut out from the tarsal conjunctiva or from the road, amplify these stresses. And when a patient rubs his eye, then the stresses become multimodal. Not just the radial stress, but the hoop and the shear stress come into play. And a cyclic repetition of these movements bring in creep and ultimately fatigue. Now we know from Cynthia Roberts' work that in keratoconus starts with a focal area of weakening, which then initiates a cascade of events that causes structural damage and a mechanical breakdown. But we also know that in keratoconus, there are biological factors that also contribute to its degradation. Nevertheless, both the cornea and the tire share a similar trajectory of gradual degradation, and their fatigue finally expressing itself as an ectasia. Interestingly, both are treated by cross-linking. In fact, the tire industry is the birthplace of cross-linking. It was way back in 1839 that Charles Goodyear accidentally stumbled upon this technique that came to be known as vulcanization. But why am I making these comparisons between cornea and tire? It's not like they were twins separated at birth. The creators made them for entirely different functions. But here's where we take a leaf out of Dr. Rao's Book of Wisdom and ask ourselves, are there lessons from the tire industry that we can learn from? And here are some of my thoughts on that. Both the cornea and the tire share the same geometry and therefore obey the same laws of physics. The membrane stress equation explains why the corneal curvature changes and how it can be made to change if we change the material properties or the tension that works within it. Where would we apply this knowledge? Let's take keratoconus as an example. Today we have multiple options in treatment. But with that comes the responsibility of making the right choice. The surgeon today is staring at questions he has no clear answer for. If you chose a cross-linking, what should be the target tensile stress and how do you achieve it? If you chose to put an implant, what should be its geometry? Where should it be located? What should be its properties? The starting point to answer these questions would be to understand the stress distribution in a normal and an unhealthy cornea. One way to do this is to do a finite element modeling. Now, this can be very time-consuming and very challenging for a biological tissue. But luckily, the tire industry has a robust model in place. And all we need to do is to adopt and adapt it, of course, to the specific corneal characteristics. This too is more easily said than done, but this should pave the way to a more rational construction of a treatment algorithm. Another lesson that material science has taught us is to distinguish between strength and stiffness. We are often guilty of using them interchangeably, but one is the resistance to break, the other is a resistance to deform, and these are two different things. Let's illustrate this again with the keratoconus. The Bowman's layer has the highest stiffness, but is not strong, and that's why you see breaks in the Bowman's membrane early in the disease. The stroma, on the other hand, is low in stiffness and prefers to bend rather than break. Let's see how this plays out in a clinical scenario. Here is the axial map of two eyes of patients of nearly the same age. The one on your right is almost 10 diopters steeper than the one on the left. Counterintuitively, it is the flatter cornea that actually developed the high drops. And if you look at the Scheinpflug images below, you would see structural changes occurring at the level of the Descemet's membrane. So one little rub of the eye was enough to snap the Descemet's membrane. So we've understood that damage is a gradual chronic process, whereas failure is an acute event. A rupture, whether it happens in the cornea or in the tire, is repaired the same way with a graft. But while our friends have an endless supply of rubber, we suffer from the paucity of corneal tissue. And this is one of the reasons why there's such a thrust on bioengineered corneas. There's a lot of work being done in this direction, and I know that there are many here who are already in that field of research. But two studies caught my attention because of the attention paid to improve the rheological properties of these corneas. The first used carefully selected biopolymers and a method of cross-linking that uses visible light. The second uses a novel technique of double cross-linking with a chemical and a photochemical method. Both achieved good rheological properties. But a word of caution here, and again, this is where the tires have taught us this lesson, that in spite of being vulcanized, you may get these cracks in the rubber. Rarely, you also see the same thing happening in a cross-linked cornea where the Descemet's membrane appears fractured. Now, whether this happened because of or in spite of cross-linking is hard to establish. But the question it begs is, can excessive cross-linking make the tissue more brittle? And this brings us to another property, tissue property, which is very familiar to people in the tire industry, but which hasn't had its share of importance in ocular biomechanics, and that is fracture toughness. It is a measure of how much stress is needed to extend a pre-existing tear. And it is done very frequently in the tire industry by what's known as a single rip tear test, or more colorfully called the trouser tear test. If we knew this property in ocular tissue, we could understand the dynamics of ocular trauma and how to repair them. And interestingly, this was done for the first time in Dr. Rao's own backyard. So if this can be incorporated, it would make bioengineered corneas and stromal constructs more nuanced. We can keep bouncing along with these tires and listen to the tales they tell, but I will end here by defying a well-known adage that golden words are never repeated, because I believe that some golden words need to ring loud and clear, especially in forums like these. And on behalf of all of us, I would like to thank Dr. Rao for being such a fountain of inspiration to all of us. We will continue to look up to you, sir, for your guidance and wisdom. Thank you.